if you look even back in the late 1990s, probably median survival for someone who relapsed after an autologous stem cell transplant was about 10 months. And it's clearly much longer than that now, which is primarily due to all of the novel agents that have gained FDA approval in the past 10 years or so. So it's a really exciting time. And whereas for many years what we were studying was just classic cytotoxic chemotherapy, radiation, now the agents we're looking at are more novel. How do we get the immune system to work better to fight your cancer? And so one of the first drugs that was FDA approved specifically for this indication was brentuximab vedotin, and that was way back in 2011. And that drug initially was approved for relapse after transplant or after 2 or more lines of prior therapy, but now has been moved up into sometimes with frontline therapy as consolidation after stem cell transplant. And so it's getting used earlier and earlier in treatment plans. So I think how we're going to go forward using it in these patients who've relapsed later is not going to be as clear because many of them may have already been exposed to that. But for some patients, if they got a long remission, you might consider doing that. But more recently, we've also had some what are called checkpoint inhibitors, pembrolizumab and nivolumab improved for the same indication. And this really is working more for how do we get the immune system to work, and have had really exciting responses to this. The important thing I think for clinical oncologists to know when using these drugs is that the response to the checkpoint inhibitors is not monitored in the same way as kind of our classic chemotherapy. So whereas traditionally we've had patients who have a complete response or a partial response, progressive disease, with patients who get these checkpoint inhibitors, sometimes they have tumor flare or sort of pseudoprogression, where you treat them and they're feeling well, but you get their scans, after 3 months or so, and they look worse. And so a few years ago, there was actually the LYRIC criteria, response criteria made, and they used the kind of classic Chesson criteria of partial response and CR, but they add another indeterminate response category. And for this, you could have a patient who actually has had progression, like 50% growth on their scans, or a new lesion even. And as long as they're doing well, and they're feeling well with no sort of significant clinical progression, you can continue them on these checkpoint inhibitors and re-scan 3 months later and see how they're doing. This is very different than how we approach other things. So sometimes we'll have patients who we've been treating for months and months and months. Their scans don't look any better, but they're back at work and feeling really well. And so you have to take into account how is the patient actually doing when making decisions for that. So that's a very exciting time. And now what's coming next is a lot of research. How do we combine these? We're seeing higher response rates. Well, we haven't had the randomized comparative studies, but just looking at small phase 2 and phase 1 trials, we're seeing very high response rates when we combine different agents. So combine brentuximab vedotin with a checkpoint inhibitor or agents with chemotherapy and things. So how will that come in the future? And then at UNC, one of the big things we're doing is CAR T therapy. So this is a big deal for lymphoma in general. For Hodgkin's lymphoma, what we're targeting is CD30. And so we've completed our first phase 2 trial of that, phase 1, phase 2 trial, and found some really exciting responses. So patients who had classical Hodgkin's lymphoma, who had evidence of disease before their CAR T, we've seen response rates of over 60%. Now we're into the follow-up of how long do they last. So far, for the patients with the optimal preparation and for getting CAR T, we're seeing a median progression-free survival of a bit over a year, but our follow-up is still really short. So we will find out, are these durable in some patients? And are now working on developing sort of what's the next CAR T drug, hoping that we can get an even better one for these Hodgkin's lymphoma patients. And so I think the important thing to know is that there are a lot of really great options for these patients, and they're increasing in number, and people are living much longer than they were before.